Good morning. Thank you very much for giving me this opportunity to share some of our work modeling cost effectiveness. This is really a team effort that represents the work we've done at Stanford as a group. Again, I'm Jonathan Parker. I'm a neurosurgery resident at Stanford. So as we nicely heard from Dr. Elias just a few minutes ago, there's really good phase 3 data now to show both the efficacy and safety of MR-guided focused ultrasound for both improving tremor scores and also improving quality of life. The next biggest thing that we really need to do is determine how does this compare to other treatment modalities such as deep brain stimulation, stereotactic radiosurgery, and also importantly in this age of limited healthcare resources, what is most cost effective? So given that we have limited resources, it's really critical that we try to decrease the cost of these procedures, both first to be able to improve access, to make sure most people can get access to this who need it, and finally to reduce societal costs, both from the treatment itself and also from the impaired quality of life. And for the purposes of this talk, societal costs will be defined as what the reimbursement for the procedure is. So in order to do this, we developed a meta-analysis paradigm. So we first did a literature search to look at all studies that have looked at either deep brain stimulation, stereotactic radiosurgery, or focused ultrasound for essential tremor. We then extracted data from this, and we really focused on the part C of the tremor rating scale, really the activity of daily living, the important part of how the treatment affects life. And then we compiled data both from activities of daily living, also the complications. And we pooled this and did a utility analysis, which I'll speak about, and then combined with cost estimates to then determine what the success threshold would be. And the way that we defined this was really to do a decision analysis model and used a Monte Carlo simulation to step through a decision tree like you see here with numerous different simulations to define what the success threshold is or the cost effectiveness for these various treatments. So just briefly to look at the cohort of studies that we were able to glean from the literature, as one might expect, there was more patients that we could look at for deep brain stimulation, followed by stereotactic radiosurgery, and finally by the MR-guided focused ultrasound. We looked briefly across the demographic variables. As you would expect, there was differences among the different cohorts, both in age, which were approaching statistical significance, and also for length of follow-up, as we would expect, focused ultrasound being one of the newest comers to treatment for this disease. So first what we wanted to look at was utility. So utility really can be defined as a % improvement of activities of daily living, such as handwriting, drinking, other things that are judged by the tremor rating scale part C. We then looked at mean utility parameters and both pooled these from the studies and then weighted them on the size of the study and then put that into our decision analysis model. So what we found right off the bat is MR-guided focused ultrasound had superior utility when we looked in comparison to deep brain stimulation or stereotactic radiosurgery, as you can see here. We next wanted to look at complications. So this is something that's hotly debated, but we sort of made this determination between major and minor complications. Major being those that would either potentially increase cost or have increased costs associated with them or prolonged hospitalization, minor being those that didn't reach that criteria. So we looked again across the cohort of the published studies looking at major complications. As you can see here, the MR-guided focused ultrasound as a group had the lowest major complication rate, then followed by stereotactic radiosurgery, and then deep brain stimulation. We also looked at the utility deficit, basically how much of a % change in quality of life would be affected by these complications. And we found that stereotactic radiosurgery took the biggest hit, likely because of incidence of weakness and hemiparesis, but there was not a large utility deficit to MR-guided focused ultrasound, despite some of the major complications. We next looked at minor complications. Again, MR-guided focused ultrasound had a slightly increased minor complication rate, but you can see there on the bottom right, the utility deficit was really inconsequential because these were small minor complications. So next, what we wanted to look at is cost. This is obviously a very important thing to consider with a new treatment modality. So the first two, deep brain stimulation and stereotactic radiosurgery, these numbers are based off of established Medicare reimbursement. When we talk about unstaged versus staged, this is whether or not we do this in a 2-day procedure for deep brain stimulation. And you could see the values here do change for whether or not we do this in 1 or 2 days. However, we did not find any convincing evidence in the literature that there's differences in the outcome of the procedure of deep brain stimulation based off of unstaged or staged. We then looked at established reimbursement for stereotactic ultrasound. And then finally, we generated an estimate, this is very preliminary, for focus ultrasound. This was based off a kernel of the stereotactic radiosurgery reimbursement, and then adding 4 hours worth of intraoperative mapping procedure charges, and then also additional costs for MR imaging. So what we can say, at least very preliminary, is that the procedure costs that we estimate for MR-guided focus ultrasound are at least comparable to that of stereotactic radiosurgery, and likely much less than deep brain stimulation. Again, this is just an estimate based off of the parameters that I defined. So what we wanted to look next as cost effectiveness. So effectiveness is really a metric which is the product of utility and duration. So what you can see here is the different price reimbursements or estimates. You can see some small differences in the numbers here from this slide to the previous slide. That's really due to the fact that we accounted for complications. So we did probability weighting of complications and added those costs to our estimates. As you can see there on the bottom, highlighted with the box, MR-guided focus ultrasound had the highest effectiveness quotient at a cost that was comparable to stereotactic radiosurgery and definitely less than deep brain stimulation. And these were found to be statistically significant. So what you can see here, sort of graphed in 2 dimensions, on the y-axis being effectiveness and on the x being cost. We varied many different parameters in terms of what the effectiveness quotient would be, and then various different costs. And you can see it's right sort of at the borderline between the cost effectiveness for stereotactic radiosurgery and focus ultrasound. There is a small buffer whereby the cost of focus ultrasound could increase and still maintain its cost efficacy advantage over stereotactic radiosurgery. Obviously, this is a very, very preliminary result and something that is an estimate based off of our costs. So briefly in conclusion, we found that MR-guided focus ultrasound had some of the lowest major complication rates, really allowed it to maintain high utility values despite a slightly increase in the minor complication rate compared to the treatment alternatives. We showed that there's improved outcomes for unilateral central tremor at similar estimated cost to stereotactic radiosurgery, and definitely lower than that for deep brain stimulation. And finally, even if MR-guided focus ultrasound only maintains its current level of effectiveness, there is some buffer for procedural cost to increase while still maintaining this cost efficacy advantage. So thank you very much for your time. I'd like to acknowledge Dr. Halpern, my mentor at Stanford, and the rest of the Stanford Focus Ultrasound team, without which this work wouldn't be possible. So thank you very much.
Thank you very much. We're almost caught up, so we could take a question or two.
I question the word cost. Cost is what it actually costs to do, not what the reimbursement is.
Correct.
And we're in the very beginning of this procedure, and we have very differences in the original costs and the reimbursements for stereotactic radiosurgery and for deep brain stimulation. Mm-hmm. I think the results are very encouraging to this audience. But the real study is to do it with costs. Operating room time, professional time, equipment amortization, real costs. So I think the first part of your study is very impressive. But when you get to cost benefit, you really need to talk about cost, not price.
I think that's an excellent point.
Travis Tierney from Miami Children's again. I think he's right. You're automatically setting up a straw man when you're talking about expensive DBS versus a cheap thalamotomy, so the cost is important. But one of the other things that you didn't talk about was the unilateral nature of the MR-guided focused ultrasound. whereas DBS can generally be done bilaterally for essential tremor. How does that play into your thinking?
So I think that's an excellent point. It's something that we looked at the beginning of the study. Unfortunately, to try to cast a wide as net as possible, we included some deep brain stimulation studies that did have bilateral treatment. But what we did is we set a threshold of 60%. So at least 60% of the patients in the studies that we included had to have just unilateral deep brain stimulation. So we attempted to control for that as best as possible. But I think it's an excellent point. I think there's been small feasibility studies now with the MR-guided focused ultrasound to do bilateral lesioning, but there's obviously some serious safety concerns with that as well. So I think time and more experience will help guide us in that fashion.